our health unit public meeting, and I'm prepared to call the meeting to order. And I'll ask for an agenda approval. I have a mover and a seconder on that. Judy and Reno, all in favor? Opposed, if any? That's carried. I think I'll just go if anybody's opposed, and then we'll go from there. Because any announcement of conflict of interest as on the agenda is presented to you this afternoon? I don't see anyone. So then we'll move on to the update on item 4.1, COVID-19 update. Dr. Ahmed?
Hi, thanks, Gary. I have a PowerPoint slide that I would share. All right, so let's just get to it. And as you know, the cases are increasing everywhere, and this is a picture of what's happening globally with respect to COVID-19 cases. And this is a standardized case count per million people. And as we can see, compared to many of the other countries, Canada is doing a fairly good job with respect to the containing the spread, and many of the countries, especially in Europe, seeing a very bad second wave, forcing them to go lockdown. We are also somewhat heading in that direction, but compared to some of these countries, we are still doing a better job. Looking at the daily confirmed new deaths per million population, and this is what it looks like from that perspective, that the number of people dying. And again, Canada is in a spot which is relatively still better than many of the countries that we are seeing around the world. Focusing just on Ontario, this is what the Ontario picture looks like, and it captures all the daily case counts right from the beginning of the first wave all the way up to today, as reported by the government website. And as we can see, even in the worst of the pandemic in the first wave, our case count was close to 650 cases a day, which has now exceeded to double that number. And there were days when we even reported 1,500 cases a day. So things are getting worse everywhere, including in the province. This is the data that was collected November 10th, and it shows the trends in the hospitalization in Ontario, including the COVID-19 cases in ICU as well as in person. So it's showing that the data is heading definitely in the wrong direction with respect to the morbidity and mortality that we may expect from COVID-19 here. So focusing in entirely on Windsor-Essex, this is what the picture looks like right from the beginning of the pandemic. So we can see that in September and early October, we have seen some good numbers, and now we're seeing another uptick of cases beginning from November. And partly we're thinking that maybe it's started off as a result of post-Halloween parties and everything. Focusing just on from September to November, this time it gives us a better picture of what's happened in the month of November, where the cases now we are reporting regularly close to on an average of 20 cases a day. And the other question that we wanted to differentiate with respect to Agri-Farm, because we have a significant number of Agri-Farm workers in our region. And this graph shows, we did had an outbreak in the Agri-Farm with the cases that were identified, but there are a number of community cases that we are seeing, and many of these cases are still as a result of close contact, but highlighting a trend that is getting into the part where it's not necessarily just one sector, but it's spread pretty much everywhere, and a lot of them could be linked with the community transmission that we are seeing. Our 7-day moving average for case counts, as we can see, it is going up, and right now we are coming closer to some of the numbers that we have seen in the with the first wave, and we definitely want to bring it back to a level which was at least less than 10 or less than 5 in our region. Looking at hospitalization in Windsor-Essex, we can see that the hospitalization was a much manageable level in Windsor-Essex, specifically for COVID-19. This is just COVID-19, not showing the full hospital capacity. Hospital is already working close to almost 90% of the capacity at this time, but this particular graph is showing only the hospitalization and as a result of COVID. And we can see that the trend is changing, and the cases of COVID-19 in hospital and in ICU is increasing as well. So this particular graph now focused more on what's happening in the month of November. So it's just showing that similar trend. In the last 14 days, this is what the graph looks like from the uptake perspective. And from an exposure perspective, what we are looking here is the cases that we are seeing in green. It's a result of a close contact. And then in yellow, we're looking at the cases that are as a result of a community transmission. And we're still seeing some cases as a result of travel related. And the travel range is all the way from a trip to Michigan versus all the way from international trips as well, where people are coming from. But what we are seeing still mostly is most of the cases are still as a result of close contact, but the number of close contacts is much higher than what we were seeing in the first wave. So something that's a concerning trend, and pointing out to the fact that either people are having more close contacts, or some of these close contacts are resulting as a result of social gatherings that we are seeing. So we are already reporting a significant number of cases for last week, and this week is no different than that, but this week is still ongoing. Comparing it from a weekly incidence rate, this is the number that the province is looking for us in terms of our progress with respect to COVID. Last week, for week 46, we reported a case rate of 41 cases per 100,000 population. Week 47 is ongoing, and we'll do that. It ends on Sunday, so we'll have a better picture on Sunday about what week 47 is bringing for us. So this is the graph. Another graph is the province look at us for with respect to person positivity, and it basically shows if what's the positivity rate of all the tests that are conducted in Windsor-Essex. And as we can see, this trend is increasing, and we are as of November 14, we are close to 2.9% of person positivity, and there were approximately 4,500 tests that were completed between November 8 to November 14. So this graph looks at the effective mean reproduction rate, and as of November 18, the median effective reproduction rate is 1.1. This has consistently been above 1 since October 23rd, and because of our high number of cases, the further transmission is relatively limited, but we're still seeing a trend that is higher than where we would like to see. Some active COVID outbreaks in all the settings. This is basically just showing what's happening in the long-term care home, retirement home, workplaces, and also schools. As you know, there are 3 long-term care homes that are currently in outbreak. We have declared another outbreak in one of the schools. So now the school, there are 2 schools that are currently in outbreak. And in addition, there's a farm that is currently in outbreak. And we had a community outbreak that is we are about to rescind that community outbreak that was linked to the University of Windsor residents. So this graph looks at the percent of new cases that are acquired in the community based on the 7-day average. So overall, what we are seeing is the percentage of these cases are going down, but if you factor that in with respect to the actual cases that we have, then still it's higher than where we'd like to see. So yes, it's most of these cases are still linked with close contact, which is a good sign. It's helped us to identify those close contacts and contain it. But on the other hand, more people are having more close contacts, and that's why we are seeing those clusters in these settings. So this graph further breaks down to what it looks like from an exposure perspective. And our community cases are looking like close contacts due to social gatherings, household contact once they are imported, or then outbreak related in a setting travel from outside of Ontario and from the community where the source is known. So as you can see, it's pretty much everywhere in the last few weeks, with most of them are still as a result of an outbreak, which was linked to the Agri-Farm as well as from the long-term care home. But we still have a significant amount of community transmission in the red we can see in this graph. This is the percent of cases by exposure type in the last 7 days, and this is something that we want to see so that understand what exactly happened in the last 7 days. So as we can see, the majority of these last cases in the last 7 days were linked to an outbreak, but there are a number of cases that we are seeing from as a result of close contact or household contacts, and also community cases, which constitute roughly around 15% of the cases. So from a health system capacity perspective, our health system capacity as of November 17th is 92%, which is, again, it crosses that threshold of 90%, and recognizing that many of these cases, when they're admitted for COVID, they require isolation room, which puts the a pressure on the hospital system to find those isolation rooms. Intensive care bed utilization, as we can see, it fluctuates quite broadly, but as of November 17th, the ICU capacity is close to 80%, which is also triggering a shift in terms of the pressure in the acute care system. From a ventilator bed capacity perspective, so far it's okay given the amount of ventilator beds that are available. So we are at 40% of the capacity. From a public health capacity perspective, between November 3rd and November 9th, we were able to do 86% of cases and 96% of contacts notified within 1 day of being reported to public health. And with the surge of cases in the last few weeks, we are seeing a slightly decline in terms of us reaching out to all these people, triggering, identifying a pressure in our system too. Partly because of our ability to contact these people in a timely manner, either because of the delays in reaching out to them and getting a call back. And so all of those issues are signaling pressures in our system. So in summary, what's happening is case counts in the region is increasing at a rapid rate, and most of these cases are still resulting from close contact, but also triggering that most people have more close contact than they should. Social and private gatherings are still one of the important sources of transmission, and we have all these schools and agricultural farm community outbreaks still ongoing. And as we are shifting more our focus on the enforcement side of the things, we're working with all the municipalities to do more work in the enforcement section, and working closely with all the police partners and the municipal partners to do that. Happy to take any questions. Thank you.
Any questions, members of the board, to Dr. Ahmed? The only question go ahead, Joe, go ahead.
Thank you for your leadership. As you know, especially when the school started, there was a big question mark, a lot of anxiety, and there were a few hiccups in the schools. As you know, they're in there, and I want to commend your staff, the public school health nurses that are assigned to those schools. They do a fabulous job with controlling, comforting the school community, as well as, helping out with the parents when they come and pick up the kids. So they're a valuable resource, and thank you for the work that everyone is doing on that front.
Yeah, I know Teresa is personally involved in many of these case discussion with the staff that are doing all these cases, and then we all work together. We have a team, but Teresa is listening. I'm sure that maybe she may have a comment on that.
Dr. Ahmed, could you explain, when you say cases are under investigation, is that where you're trying to slot them in the, in the community spread or home or whatever? Is that where you're trying to pinpoint exactly?
So yes and no. So sometimes, let's say if we reported 27 cases today. So as a result of those 27 cases, we investigate them, and so we are trying to connect with them. We're in the process of establishing that contact. Sometimes we have some data that helps us in our investigation, and then further data is needed to classify them, as you said, whether they are close contact, whether it's a part of outbreak, and then sometimes that information changes. And once that information is complete, only then we are able to pinpoint exactly that where they belong. Because if some of them are already identified as close contacts and listed and already isolating, we can easily link them. But there are cases that require some further discussion to put them in the right category. So that's what it happens. But we tend to compile all this data and information and report it on our weekly data, and this is all reported regularly back to the community.
Okay, thank you. Any further questions or comments? If not, then
I have a question.
Go ahead.
Can you explain to what happens with isolation, testing, etc., when a group is sent home from a school, like a class, or, for example, there's been a school closed? Are the families expected to isolate as well, or are there families then going back to workplaces and possibly exposing others? What's the process there?
So I'll let Teresa talk about that. But I'll let her explain that. I think she can do it much better.
So the cases, if there's a case in a school and a student or staff, the case goes home and self-isolates from everyone in their household. So they are a case. Anyone else in their household and anyone at the school, like a school cohort, would be deemed high-risk contacts. High-risk contacts of a case do not have COVID, but we are watching them. So they go home and they self-isolate as well. And we recommend testing on day 5 to 7, or if they get symptoms. If they get symptoms, we recommend testing as well. So they are isolating. So if you're a high-risk contact and you're sent home as a child, then you are the one that you're isolating, trying to stay away from your family members as best you can, but you're not a case. So your parent would be a contact of a contact. We don't worry about those people unless they become a case. So the parents and everyone else in the household, they're contacts. We want them to stay away from the high-risk contact or the case, but they're not, they're a contact of a contact. They're not the concern at that time.
Okay, thanks.
Fabio.
Thank you, Chair. My question is around provincial guidelines. And Dr. Ahmed, in your presentation, there were some slides that looked at capacity within our health system. And we're so far not at a high risk position with respect to capacity. There's still quite a bit of room within our healthcare system. When the province determines the status of a region, how much emphasis is placed on the capacity within its healthcare system versus sheer numbers? And I assume both are looked at holistically, but is there weight given to the capacity more than just the numbers themselves? Because both tell us different stories, and our ability to manage the numbers, I guess. So if you could provide insight there.
Yeah, so the first and foremost thing that they're looking for is the case counts, and that's the initial screening point. What we're looking at is what the case rate is, and in order to capture day-to-day variation, they like to look at weekly case rates, and that gives us an indication of what is happening over the last 7 days as a moving average. And based on those last 7 days moving average, then the other thing that they look at is I mentioned about the person positivity. So if the cases that are going into the assessment center, how many of them are coming back positive? So that's the second criteria that they're looking. The third criteria that they're looking at is the effective reproduction rate, and essentially meaning how many cases are being produced by one case if they're positive. So those are the initial data that they look at, and if those data is pointing to a pressure in any of these areas, then they look at, okay, what's the health system capacity, public health system capacity to deal with that? And if we are seeing that, yes, we have high case counts, but let's say based on either as a result of outbreak and those outbreaks are well managed and contained, there is no ongoing risk to the community. And despite the case count, they may think that, well, it's still contained. It's not adding up too much stress in the community. And then they make a decision that way. But generally, those are the three key indicators that they're looking for: is the case rates, weekly case rates, person positivity, and the effective reproduction rate. And then the rest of the data is just there to support or just provide us a little bit of cushion to wait and see approach.
Thank you. That helps clarify, and it helps me understand kind of our risk exposure from a variety of lenses. So I appreciate that. Thank you.
Reno.
Thank you. Just wondering, when the province deems us to be able to move from one level to another, do we get a heads up? Do we know in advance? Are we able to prepare or deal with it, or is it something where you learn from the briefings provincially as they come up?
We generally get a little bit of notice, sometimes an hour or 2 hours notice. Very rarely we get a long time before we get to that point. The data is the data that the province asks us to continue to monitor that data. And if the trend is going into a concerning direction, then those one-on-one conversation happens with the province for them to help understand what exactly are the pressures. So if, for example, if Windsor-Essex continue to start to show, God forbid, like more cases than what we are seeing right now, the province may reach out to us, me and Teresa, and ask us, okay, can you explain about these cases, where these cases are coming from, and what are some of the pressures that we are seeing? So we report back to them. And similarly, if they're seeing a concerning trend on day to day, they reach out to us and ask for more explanation, more details. But when it comes to the decision making, they have a call, they let us know that this is what the number is, and they ask us for our perspective, the local perspective. And eventually they obviously, in the previous iteration, it was not clear what would happen, what kind of restriction would come. But with this framework, at least they already know what those thresholds are. So when they're having this conversation, we're having those conversations specifically about those thresholds and see what does it mean for us locally and how we can explain that number. And those decisions are then forwarded to the cabinet, and then the cabinet makes that decision and pass it on to the premier to make that announcement.
Do you have a sense of a projection of, if we keep at this rate, when we might go into, assuming the numbers continue in a negative direction, when we would expect to go into, orange next?
Well, based on the data that we are seeing right now, I think the province is looking at those decisions every week. And so they will look at our data tonight, and then some of those conversations may or may not happen tomorrow to let us know what their thoughts are, and followed by the recommendation to the cabinet, and then for the province to make that announcement. And when that announcement happens, just like last time, if the announcement was happening on Friday, the implementation date starts on Monday.
Do you have a sense as far as, looking at our numbers, knowing that what the numbers were today, where you might think we'll land for next week?
What we are looking is obviously the numbers, and it's out there. So basically, if we go strictly with what the criteria are, we are in the orange zone basically based on the numbers. But again, some of those decisions will have to be made by the province, looking at our whole picture and understanding our needs.
Okay, thank you.
Any further questions to Dr. Ahmed? Yes, Ed.
Ahmed, when we have the number of cases are rising, and before the ministry make a decision whether to move us from one phase to another phase, is it normal for them to meet with you or possibly to communicate with you and find out the reason for it before they make any decision?
Yeah, thanks, Ed. So generally, I was telling to Fabio as well that they tend to connect if they are concerned about or if they don't understand the data and they want our perspective. Sometimes we get some of these conversations much in advance. Sometimes it's a very quick conversation. Basically, they just talk about the data. They just tell us this is what it is. This is what's happening, and it's more often information shared with us that they will make that announcement. And sometimes when it's in between, they do ask for explanation, help us understand what's going on, and we provide those details to them.
Dr. Ahmed, thank you so much.
Okay, further questions? If not, then a motion to receive Dr. Ahmed's report. Ed and Larry, all in favor? Opposed, if any, that's carried. Thank you. Approval of the minutes. We had the minutes before you, members of the board, of October the 15th. Can I have a motion on those? John and Joe, any errors or omission on those minutes as presented? I hear none. So then oppose. Thank you. And the minutes carried. Any business arising from the minutes? I don't see any response there. Motion to receive the consent agenda 7.11 and up to and including 7.1-4. Reno and
Okay.
Reno and Ed. Reno, you got a question? Go ahead.
Question on one of the reports with the CTS application. I'm just wondering if Teresa can speak to, it mentions working with partners on potentially co-locating or seeing with that. Is there discussions, is that discussion wide open? Is it potentially new location, current location that where one of the partners are located, or is that at this point, is that discussion wide open?
Teresa?
So that was recommended to us through our legal counsel that we could bring it to our wider partnership group. We did bring it to our CTS advisory group, and then also sent an email to our WeCost leadership group to see if anyone would be or had a potential location or was interested in a shared space. There wasn't any options that were presented to us. So we are moving forward with meeting with going to the next step to get a real estate agent. And we are working closely with our legal counsel to make sure we're doing all of the steps in full transparency. So that actually, Lori has a meeting tomorrow, and we hope to move forward with our coordinator, who's still, his primary focus is to work on getting the location identified and the community consultations, and help move the application forward.
Okay. Thank you.
All right, thank you for that. On the consent agenda, is there anything that administration want or should highlight in their report? Okay. Move on to new business. 8.1, again, our quarterly reports, and then Teresa.
So you will see that every quarter there's a CEO compliance report, and we have been a little delinquent in getting them completed in a timely fashion. But we wanted to highlight that at the end of the quarterly reports, we are identifying that due to the pandemic that programs have been suspended, staff have been redeployed, we've canceled deferred vacations, that there are some, issues. The report is just identifying the circumstances that the pandemic has brought forward. So now we're caught up with the 3 compliance reports.
I can tell you that it's not because of lack of time. It's been an extremely busy time, and I can see from your report, Teresa, that although there's been so much work and attention onto COVID-19, we certainly can see that a lot of other efforts of the health unit to maintain all of the responsibilities have certainly been maintained. So certainly kudos to your leadership and certainly to Dr. Ahmed and all of the senior staff for keeping, as they say, keeping the doors open. And so thank you for that. Any questions, members of the board, to Teresa at this time? It's not, then I would entertain a motion to receive the report as presented. Reno and okay, Judy. Oppose? Caught you there, Fabio. That was my fault. That carries. Thank you. Okay, 2021 Board of Health, the meeting schedule, that's also for the perusal of the council. If there's anything they are concerned for them, for yourselves. If not, then a motion to adopt the schedule for 2021. Deborah and Ed. Opposed? Then that carries. Thank you. Move on to 9.0. There's resolutions there, and I guess we'll do them all at once, or do them one at a time. I think or do you want information? So we've got 9.1. It's a letter that was sent actually to the Right Honorable Justin Trudeau and the Honorable Kristen Freeling. That's basic income during and after the COVID-19 pandemic. This has been something that's been on our radar for even prior to COVID-19. And so that's there for information. 9.2, Gray Bruce Public Health Unit letter to to Patty Aju, our Minister of Health, as well as the Mary Lee Fulton on the long-term care COVID-19 Commission and the COVID-19 long-term care reform supporting Simcoe Muskoka District Health Unit's letter regarding the same. So go ahead, Reno.
Just a quick question, more sort of procedurally, maybe looking at 9.1 specifically with the basic income letter. That's sort of weighing into something that's I'll say not directly health related, and it's sort of political. So I'm wondering what the process is as far as to sort of stand behind an issue like that, to go to a point of advocacy on it. And full disclosure, I'm supportive of it, but I'm just curious as to that process, as to is it because some of the other health units were leading the charge, and so we're sort of adding our voice, or is it, and does that discussion happen at the board level, or is that something that is led by Dr. Ahmed and administration to take that position and then move ahead with it? I'm just curious of the process, because it seems to me this is a political issue that we're weighing into, and gladly, but what's that process?
Well, I think Nicole, it's Nicole that's been heading this, but there is, some correlation, obviously, into public health and that. But I'll let Nicole weigh in on this, because I know, Nicole, you've been working on this for quite a while.
Yeah, I won't speak for Dr. Ahmed or Teresa on the points that you asked, but I just wanted to note that our board has, and you're right, Mayor McNamara, I brought it forward in the past. So our board has supported a resolution around the basic income. So it already is something that this board has endorsed formally, and we have a resolution standing in relation to it and have provided letters in the past. Mostly around the issue of food insecurity is the common link, but certainly as it relates to social determinants of health, it's an issue that we think is important. But I just wanted to note that there is a standing resolution for our board.
So, but even before that resolution comes, like, is it simply because people have reached out? There seems to be a momentum gaining with more than one area, because to that point, I mean, there's I would say there's many issues that we can advocate for on a political front that are tied to similar social determinants of health. But is it just something where through some studies and through research that we decided to go heavy on, so to speak, as opposed to other issues that are in the community? Or is it something that's brought to us that we then attach ourselves to? And maybe that's just for Gary. I mean, I guess from a perspective of in that scenario.
Well, a lot of it, I mean, indirectly, meaning indirectly. Obviously, the social determinants are, nutrition, living capabilities, and so forth, all play into trying to build a healthy society. And as we all know, the difficulty of many families that are living in poverty, it's the affordability of to be able to feed their bodies properly, and so this whole issue of basic income is to help support the basic requirements for society to be able to sustain themselves in a better way. And I think this was the rationale why the health unit pre-COVID certainly supported the initiative because of that. And so it's to make sure that our society, that especially those living in poverty, is to bring them up to a level where we can accommodate them to make sure that they get the proper nutrition, because we all know that's something that we as a health unit advocate, to make sure that you eat the right foods at the right time, and so those social determinants, do have a reflection of public health. I think it's one of those items where it's all hands on deck to try to to promote, to get that, the level of poverty, get people out of poverty as much as we can. And so this basic requirement is something that should be supported by health units and so forth, because it's to our best interest. Okay, any further questions on that? If not, then that one, obviously, let's put them all together, and the basic income piece, as well as support letter for the Muskoka, and that's basically on the long-term care requirements, a letter regarding the same. And then Great Bruce Public Health Unit letter to the Honorable Patty Hayju and Honorable Christine Elliott, and that's the Municipal Drug Strategy Coordinators Network Ontario Safe Supply. And so there's, I believe, the recommendation from our health units to support them. Reno moves, and Deborah support. Any further questions or comments? Having heard none, all in favor, or opposed, I should say opposed. Easy. Yes, sorry about that, folks. Okay, that carries. Next on the docket is move forward to committee of the whole. I believe that's the last item in the public session. So if we can have a motion to move in the committee of the whole under section 239, John and Judy. Opposed? That carries. And Leanne, I don't know if you're controlling the